got a couple of we did have a couple of unannounced, or we still have a couple of unnamed folks on the phone.
There he is. Yeah.
He knew it. He was just making a dramatic
Fashionably late, it's okay.
There we go. The most appreciated man in the room right now. Appreciated women too. So it is 12:32. So we're going to go ahead while Brian dishes up and call the meeting to order. And we will start with introductions if we could. And I'm Rhonda Hoff, Yakima Neighborhood Health Services, representing the housing sector and chair the GCACH, and we will go counterclockwise, I guess, today with introductions.
Hi, I'm Eric Nilsson. I'm with the Kennewick Fire Department representing public safety.
Lauren Johnson, Greater Columbia ACH.
Ashley Fernandez, Greater Columbia ACH. Horace Engels, Coordinated Care Observing.
Carrie Green, Three Rivers Community Foundation, representing philanthropy.
Jenna Shelton, Greater Columbia ACH.
Carol Moser, Greater Columbia ACH.
Jorge Rivera Molina Healthcare, representing MCO.
Wes Lucky, Greater Columbia.
Ronnie Baxler, Lord Health Network. Thank you. I almost said the other one. Representing consumer.
Dana Otis, the Lord's Health, representing behavioral health. Rachel Guest of Greater Columbia. Diane Halo of Greater Columbia.
Becky Colm, Greater Columbia.
Brian Gibbons, Street Sunnyside Hospital, representing providers.
Okay, and on the phone, let's see, I see Darlene. Darlene, can you speak?
Yes, Darlene Darnell, Catholic Charities, representing faith-based organizations and community-based organizations.
Okay, and Samantha?
This is Samantha
Sam Bordeaux,
Greater
Quality
Columbia
Behavioral
Health.
Okay, so let's start with Samantha Frederick. Sorry about that.
You're good. Samantha Frederick, Quality Behavioral Health.
Samantha Ward, or Sam Wardell.
Sam?
Greater Columbia.
Okay, so did we mute her? Did we just mute her? Okay, so Sam, we can't hear you, but we're going to announce that you're on the phone, Sam Wardell. And then we have callers 1, 2, and 4. So if the three of you could introduce yourselves, that would be great.
This is Madeline Carlson with People for People, representing transportation.
Madeline?
Sarah Clark with First Step Community Counseling Services.
Did you get that, Lauren?
Yep.
Okay, thank you. And there's at least one other caller on the phone. Okay, is anyone else on the call that would like to introduce themselves? Okay, have we got everybody in the room? Does everyone introduce themselves? Joelle
Chavez, CHPW.
Anybody else?
Sorry, Sierra Foster from Assured Health.
Okay.
And then one more. Martin Sanchez, Greater Columbia ACH.
Okay, Martine, thank you. Okay, great. Okay, so we always start the meeting by asking everyone to review the attestation of the conflict of interest and the self-dealing transactions. So if you would take just a minute and review those statements. And then looking at the agenda, please either now or when we get to that agenda item, if you would speak up if you believe you have a conflict of interest on any of the items on the agenda.
Rhonda, I have a conflict of interest on one of the items on the agenda, so I'll be abstaining from that vote.
Okay, which item?
It's the SBAR regarding, yeah, where's it at? I've lost my, yeah, the EMS Community Paramedicine SBAR.
Okay, thank you, Eric.
And I also have the mid-adopter funding allocation. I will abstain from that.
Okay, so we'll talk about that when we get there. Thank you, Dana. Okay, so then we will move on to the consent calendar. And the item under that is the meeting from the April 25th meeting, which was the board retreat. And I read the minutes. I wasn't at that meeting, unfortunately. So, Carol, are there any high points from the retreat that you would like to call out before we ask for approval of those?
Not really. We ran through a financial analysis for the board members so that they could see what the cash flow might look like from now until the end of the demonstration, which I think helped enable the conversation to look beyond, what's happening or what could happen in the future. We put those in a table format as they were presented by Chris Keller. And then at the end of today's meeting, we have a crosswalk that was based on the comments that we received so that we could show the board some of the activities that are already transpiring, even before 2023, that are meeting some of those desired changes.
Okay, well, just looking through the minutes, it looks like it was a very fruitful and lots of discussion that happened there. I don't know if other people that were at the meeting, if you would like to share any kind of observations or comments from the retreat. We're sorry to miss it.
Sure, I was actually at it. The meeting was very, very good. The discussion, we had an opportunity to talk about, maybe what we thought the flavor of the sustainability might look like. And it came to the conclusion that somewhere along the road, we want to create rather like a consulting arm, opportunity for the company to develop and sell services to other healthcare companies, kind of a convener company that provides services that enhance the ability of facilities and other organizations to sustain the good work that's been done here through PCMH and other. And there were a number of different angles along it. But sort of the direction was to move towards a consultative environment, create a sustainable opportunity that way. So it was very, very good.
When I read the minutes, it made me think sort of like the Educational Service District.
Mm-hmm. Yeah, very much like that.
Kind of a flavor like that.
Yeah, it was good. It was very good.
I think you termed it the Center of Excellence or something.
Mm-hmm.
Yeah, they came up with that.
Dana?
I would totally agree. I think there was really good dialogue and discussion about, future endeavors and what we could look at. And it was a good meeting.
Ronnie?
I think that it was very thought-provoking, and it kind of gave me a feeling of an entrepreneurship moving forward. What can we do? What kind of things can we put in? How can we be a support organization and that moving forward so that there's an income base that can financially sustain it, but also what kind of community, almost like a liaison, to bring in community together, because that's what this organization has done very well.
Yes, that was an important point. That was great.
I do want to know that the data information that was shared as context for the discussion was very well done.
Oh.
Very gave a lot of context and gave a 4-year view. So that really sets us all in the reality, not only today, but 3 years, 4 years down the road. And that really allows for you to be creative and realistic on what situations, different scenarios can be.
Did you feel like you received new information in the data or new insights to the data?
That's a tough question because I think it's more like the way the information was articulated that really made sense and gave context to the particular conversation because we have seen some of those tables before, but I think the projection over 4 years of cash flow that really in one column on the side says this is how much cash flow will be left in year 1, year 2, year 4, really gives the context of how much time we have to work on sustainability. What other things you're seeing coming to add or challenge the current cash flow. So I think that was very, very helpful for the sustainability conversation.
On the phone? Oh, sorry, I was just going to ask if there were people on the phone that had comments. Sorry, Madeline, did you like to say something? I'm sorry, I couldn't hear. Okay, so if you're not speaking, if you could mute your phone, that would be great. And then I'm going to ask again if there is anyone on the phone that would has any comments from the retreat that they would like to share.
And unfortunately, I was not able to attend either.
Okay. So is there anyone else on the phone that has comments?
You don't need the floor.
So, okay, so let's, I have a question, but let's go ahead and approve the minutes first, before I throw my question out. So,
I move that the minutes be accepted.
okay.
I'll
Approved.
second.
Okay. Motion by Ronnie and second by Jorge. And any further discussion? All in favor?
Aye.
Aye.
Anyone opposed? Any abstentions? I guess I abstain. I wasn't there.
Okay.
Okay, so I guess my question then is from the summary of the minutes, or from just reading this and the discussion, it seems like there was a consensus that the board really feels like the GCACH in some format should continue.
Right.
And so in terms of how that happens, I know we have some funding in our budget for grant writing, and I'm wondering, I'm wondering if this is the time that we should be talking about actually bringing on a full-time development director to help us move toward that end. And I wanted to throw that on the table because that really helps us get there and not wait till the last minute to be looking for ongoing funding to help for that purpose. So I wanted to put that on the table and see what people thought as a result of reading the minutes. So.
I mean, there's grant opportunities that come up all the time. We just recently completed a TIA grant that helped support the opioid summit that's coming up in June, and I think we're getting $50,000.
$50,000. We did great. It's awesome.
But we've seen other grant opportunities arise.
I'm excited.
One of the roles of a development director is to go looking for opportunities. I mean, there's lots of opportunities, but it takes time for somebody to be researching and not just for the $40 and $50 million projects. So, and the work that you're talking about, I think, takes a significant amount to sustain.
Right.
So again, it doesn't happen overnight, and so I know what it means for organizations like ours, and we don't have a huge staff at the GCACH that are dedicated to that, and it feels like it's the time to dedicate to that.
Right, and grant writing is as much of an art as a science.
It really is.
It does take a certain skill level to get good grant responses.
I think there, I know a couple of people that are grant writers. I mean, like, I know Penny Bell from Ideal Balance. She wrote all the grants for the opiates.
Well, before we get to talking about who's, let's see where we are, what the board thinks about the sentiment. I mean, there are people out there, but I think the first step is how does the board feel about the idea of bringing that position on as a full-time position?
I think exploring the possibility to have a position that helps us grow and have more funding streams makes a lot of sense as an initial idea. To Wes's point, it is as much as an art as it is as a science, and I work with, I don't want to say hundreds, but it may be hundreds of development directors across the state. It's hard to even point at what is the job descriptions really look like, because you go from just people asking for money everywhere to mostly grant writers. So it can be anywhere in between. Maybe one thing that we could do is to create a subcommittee to shape it up in the context of the needs of our particular organization.
I actually think that's the CEO's responsibility.
It could be,
Yeah.
but maybe what I'm saying is that it cannot just be copying a job description from Google or what a director of development for a nonprofit organization will be, because there will be 20 that don't say much of the same.
Okay.
So there should be some work of people who have some experience on interacting with these roles to support Carol in how does the specific position look like, how much is it grant writer, how much is it fundraising or community engagement or whatever that is.
And who on the phone? Who was that?
This is Darlene Rhonda. So my thought is, if we would consider a position like this, I I would recommend considering it on a contractual basis, at least at this point in time, not necessarily a full-time staff position. There's a couple reasons why. I think that potentially your time for a position like this could ebb and flow, depending upon what kind of funding opportunities you're looking at and how intensely those opportunities are, because typically once there's one available, you have about 6 weeks to get things in place. But I think the other reason would be, I think it becomes more and more critical as we move towards the end of this 5-year grant. And it's difficult at times as you're writing for funding for an organization that has millions of dollars that are available to it right now. And so that would be my consideration, to look at a contractual position that you could have a differential in hours depending upon what the need is at the time.
So, I guess I can appreciate that. I think my thought is, the only downside to contractual is that person is not 100% dedicated to your organization. And we've done it both ways in our organization, and that's the downside, is that if they're employed, then they're 100% dedicated to your organization. And, so that would be another thought.
Rhonda, sorry, you raised your hand. You were
Okay, Ronnie and
Go
then
ahead.
Eric.
So some of my personal experience with nonprofit and having an onboard grant writer, there's things that come up that are thrown, like this could be done by the grant writer and the seeking out and stuff of the grant, or the proposition of this happening or that happening. But when you do have them on board, they are dedicated. And what I found is that they seek out more at that point than if they're contracted. And like you said, there's other things, bigger fish, if they're looking for the bigger dollars to have income. So that is something to be considered. I know that when we had the part-time person, it was hell trying to get them to work for us because we weren't paying much, and our percentage versus somebody else that they were working with came priority.
Eric?
Yeah, I was only going to say, I believe your initial question was, is this something we should be looking at? And I would absolutely say yes. One of the very first things I asked/commented on to Carol when she did my onboarding for the board was 2023 is getting pretty big in the window. And we like to say, oh, it's 3.5 years away, but that goes that fast. And even if we started today, which obviously there's a lot to discuss on what that would even look like, I would totally support actions today that start moving us in that direction.
Terry?
So we've established that the new Center for Excellence will be a 501c3.
No, haven't established anything.
They haven't established that yet.
That's where I was gonna suggest the business plan needs to be
You can't, the grants are gonna wanna know your business plan. So, I think we're quite a ways off from that, whether we hire someone or not. So that's more of maybe our work on doing that. Does that make sense? Because they're gonna wanna, we start applying in 2023, they're gonna wanna know what their 2028 plan is.
So I'm looking because I'm trying to follow. So you're thinking that a development director shouldn't start writing grants until 2023?
They need to start right away.
Because the new organization has to be up and running and have a business model and a business plan. Because if we start writing grants now, there's no entity. They're not going to give to GCACH to roll over.
But a development director could be writing grants for the GCACH now. Correct?
I didn't hear that's what we were talking about.
I'm sorry,
But
I wasn't
I
clear.
thought we were talking
In
about
my
the
mind, I was
center of
thinking about that, but also as a way to continue.
Okay, gotcha.
Yeah, that's when I was reading this, that's what I was thinking. I apologize. I was
Okay,
not
gotcha.
very clear. Other thoughts, people that haven't spoken yet, or just other thoughts?
Well, I think along with what you're talking about, could we look for somebody who is really kind of doing dual, if they're working on grants currently, but also the business development of future moving forward, if we're looking at, this new business development and business plan and what that looks like, which then if they will be fully immersed, have a great understanding of it, which then springboards them into even more grant writing for the future.
Doesn't one of the other ACHs have like another entity, like they have the ACH, plus they have a business?
Mm-hmm. Well, there's the Empire Health Foundation that supports Better Health Together. And they're always getting grants that they can share with Better Health Together.
Pierce County also rolled out a separate community resiliency fund. So they have two entities there as well.
Yeah.
Their sustainability model is tied to health homes, though, which was kind of dropped in their lap by the state. They needed a provider in Pierce County, and they rose up to take that.
So would we like maybe Carol to do a little research on some ideas and bring them back to us? Yeah. Based on our conversation? Is that something that you could do?
Sure. Absolutely.
See what some possibilities are? Okay.
I think we have a couple more people on the phone.
Oh, okay. If you've joined us on the phone and haven't introduced yourself, would you do so, please?
Susan Grindle, Ellensburg.
Thank you, Susan.
This is Courtney Ward with AmeriGroup.
Courtney?
This is Dan Pizzini at a very noisy intersection in Portland.
Okay, it doesn't sound so noisy. Thank you, Dan. Anybody else?
While I'm on the phone, I wanted to make a comment about the contracting for a grant writer.
Okay, I'm sorry, who is that?
Dan, hang on just a second until we go.
Okay, go ahead, Dan.
Oh, okay. If you want me to wait, I'll wait.
No, go ahead. Let's get your comment first.
Okay, real quick. It just dawned on me that there's a lot of sort of basic materials that the organization needs to pull together that would become a part of almost any grant application. And if there's enough staff resource, it might make sense to do that before you bring a contractor on, so that you're not in effect having that done by the contractor. If you think about grant proposals, having information about governance, the makeup of the board, basic financial statements, mission, a kind of narrative about the organization and your mission and vision, those kinds of things you could pull together as raw material, and you might want to do that in-house before you bring a contractor on to pursue a specific set of grants. Just a thought.
Okay, thank you. Okay, and so before we move on, then let me just ask one more time if there is anybody on the call that has not announced themselves.
Rhonda, this is Kat. I just wanted to make sure you guys got me from CHPW.
Hi, Kat. Oh, thank you.
Thanks, Kat.
Hi.
Okay. All right. So let's go ahead. So you're going to do some research. Okay, great. Thank you. Let's go ahead and move on to the report and update. So this is Carol and staff.
Yes. The first articles are about some success stories that Jenna and her team wrote.
Yep. So the first one's on Columbia Basin Health Association. That's a site that I'm the practice transformation navigator for. Their clinic is located in Connell. It's their only site in our region. And through looking into their workbook when they turned it in, and even as they were filling out the workbook, they were able to identify some areas of opportunity, and also they found some resources to fill those needs. For example, they hired a person that will be risk ratifying their patients for their organization. They are doing a care management program company-wide as a an outcome from filling out the workbook. They saw this as a need for the organization, so they're going to be rolling that out organization-wide, and also a care coordination program that will target the high-risk patients.
And so the next one is on Chaz, which is a site that Martine and I share. And they're located in Lewiston and Clarkston, and so it's like Washington and Idaho. And part of their success story is that they're a dental clinic, like the site that we're working with is a standalone dental site, which kind of looking at practice transformation as a whole, they could have felt like this doesn't apply to them, but they really they were proactive and they just went for it. And so in their dental site, they're doing the PHQ-2, which is an assessment that shows that somebody needs behavioral health support. And so they rolled this out maybe March, and they've already at least had one patient who was identified and actually got those services that they needed just from coming to the dentist. Excuse me. And also they hired a full-time community health worker. And like I said, they're in Washington and Idaho. So obviously we said, like, make sure you're touching your Washington patients when you're doing your ED outreach and inpatient follow-up, but they yet again went above and beyond and are looking for if there's anything that has like a dental diagnosis or something to do with the teeth that a patient went to the ED for. And they're also able to spread and scale that community health worker to support their other clinics as well. So it was great.
Chris, when I go to the dentist, it creates trauma and behavioral health problems. So you'll be identified.
It's a trigger.
It is a trigger.
I have not enough cooking.
So I think Becky's up.
Moving on.
You got something to laugh about too in yours, right?
Mm-hmm. No,
Laughing.
you weren't funny in any way at all. So this pay period, we paid out to the practice transformation provider $658,000. So everyone should be seeing that tomorrow. And that was for the Q1 milestones from the contract, and all but one hospital was successful. So yay, good job, everybody. We also funded the Blue Mountain Community Foundation to facilitate their social determinants of health that were identified in their community. So they are a third-party administrator for one of our LHINs. And then final sad news, the portals will only be closed for 4 weeks, so nobody will see any money for 4 weeks. So we really tried to get everybody paid on this last pay period. Rachel worked really hard to get all the payments entered and worked with the navigators to get all the milestones and with Sam to get the milestones checked off so we could make sure everybody got their money. So hopefully everybody did, but please be nice. If we miss somebody, we'll catch you the next time.
Why would you probably told me this before, why would the portal be closed? Or is it a thing?
It's a thing. Every year they do this. They close for maintenance and to catch up, and also the IGT payments are being sent out right now, and so that's a big push for them, and so they can't. You're welcome.
Okay.
So last year when they did it, though, they took a lot of comments from the ACHA and made a lot of upgrades, and this year they're not doing that. Yep. So for 2019 so far we've paid out $7.2 million, so it's pretty exciting. Getting money pushed out. That's all I have.
Right.
Wes is up.
We're going to skip this for now.
Oh, okay.
Becky again.
Okay. Well, so Ruben's not here, so I can talk about this a little bit. He did kind of brief me on this before he has left. He's in Albuquerque at a Indian health training, right? Yeah. So he wrote this article about what's going on with the LHINs and the third-party administrators and the social determinants of health projects that we're working on with them. So we have funded all of the third-party administrators. So that's exciting. And so his article kind of talks about that. I'm not going to read it because you guys can read, but he put together a little spreadsheet that shows where the highest social determinants of health were identified by the LHIN. So that was kind of interesting. And so as they put out the RFPs, they'll be focusing on those areas, and then they'll get responses back from local agencies to help to, and then the third-party administrators will decide which one gets the funding Yakima has gotten theirs done, I know for sure, and I think Kittitas is coming in this week, and Carrie's working on hers.
It opened today.
It opened today.
yay.
Yeah, so things are rolling with that. It's exciting, and we've been getting a lot of really good reports back from the Yakima County Healthcare Coalition. They've been having a lot of good stuff coming in, so we're excited about that. That's it.
Any questions from anybody so far, or anybody on the phone? Okay.
So the next article is, I just wrote a brief report about the first quarter results of reporting. We pay our provider organizations a lot to report because that's how we get paid, is that when we do a good job of reporting to the healthcare authority, then they reward us, and then we can pass those savings or those revenues on to our providers. So since the portal wasn't quite up and running yet, Martine took the heavy lifting job of translating the workbooks into a really wonderful spreadsheet that the Practice Transformation Work Group reviewed. And obviously the red, yellow, and green are familiar icons for, red, maybe the work hasn't started yet. Green, they're on a roll, it's going in. Yellow, it's underway. But primarily, I think that the best news is that most providers are really on track with their quarter one milestones, and it will be a lot easier to report once we get the portal up and running, which I think Wes is going to be talking about. The Practice Transformation team, though, does a tremendous job in trying to get all of their provider organizations to accomplish each milestone. So there's a lot of technical assistance that's provided because we want our providers to be successful. We want them to make as much money as they possibly can make. So I don't know if you guys have any other comments about the report, the milestone report. So distracting.
No, everybody's from what we saw on the workbooks, if things are not being implemented, they have a plan as to how they're going to be rolling those pieces out. So we're always phone call away and email away for assistance.
I think the best part of that meeting was the discussion about the barriers that are happening. And as we went through the barriers, you don't see that column on this particular spreadsheet, but we talked about, well, what can we do as an organization to make it easier for our providers, or what's happening that we need to address. And that's interesting to me, because when we go to fill out the STARS, they always ask us, so what are you doing to address the barriers that your providers are having? What steps are you taking? So this is a very proactive approach in addressing barriers, and it's really part of our quality improvement strategy.
Do you want to talk about the hospital meetings, Carol?
Okay, before we leave this graph, I have a question.
Sure.
And just
kind of little.
I'm kind of going like this, trying to understand this, and I don't know if these are names or measures.
away, or you got to pull yours close?
Neither one of those is working for me.
It doesn't work for me either.
So the column on the left, are these measures or are these names?
Those are names of the organization. So the blue line lists the organization as a whole.
Okay.
That first column. The second column on the blue line, it gives you the total amount that's been paid out to the organization. Underneath, in the tannish rows, is we broke it down by site and how much money had been given out to each site.
Okay. So my question was, now that I can see it says organization, I think. So as we move forward, so this has hospitals and primary care providers. So will we be able to add like the behavioral health providers on here so that we'll be able to see all of us going across with the milestones?
Yes.
That's the idea.
That's the
Okay.
idea.
That was my question.
And then you'll see that the way that they're broken out is under each project area, because the milestones, the PCMH acts as the umbrella for all 4 project areas. And that makes it easy then to report on each one of these areas and how they're progressing.
Okay. All right. That's helpful. Thank you. So I'm sorry, Wes, I interrupted you.
No worries at all. I was just going to follow on what Carol was saying to help us overcome some of the obstacles that were talked about. We're planning on meeting with the administration from each of our hospital systems to talk to them about the alignment between patient-centered medical home and hospital systems.
And that was one of the barriers, is that sometimes the milestones don't exactly line up with the hospital business model. So we wanted to find out what can we do better to align those milestones with what the hospitals have to do.
And didn't we, when those were first identified, weren't those modified somewhat? So the hospitals had a little bit different milestones?
Especially under empanelment, risk stratification, and one other one, we rolled them up under care coordination. So we tried to accommodate it, but it sounds to me like that there might be a little bit more tweaking that we need to do.
Right.
Okay.
Right. So that's the purpose of those meetings.
Okay. Okay, great. Thanks.
Yeah.
So for the Trauma and Opioid Summit, it's coming sooner than we think. We're a month away now. And we've told the practice transformation organizations that we really want them to register by the end of this week, and maybe beginning of next week, so we can kind of do some more marketing for it and advertising, because we really want to fill those seats. I believe we're about a little over 100 people registered so far, and it actually people have been registering a lot this week, so it's been great. We did, like Wes was saying, we did receive a $50,000 grant for the trauma track, and we're really excited about that. We already completed the first milestone for that, and so we will get the first payment as soon as we get the final signature from the healthcare authority. We can invoice for that. So we're excited to be able to have that grant to help us, because it's really going to help us not have to pay for much of it. So, and with the partnership with PNWU and Catholic Charities, we've been able to work really closely with them. We have weekly meetings to go over everything that, from right now, we're addressing like the facilitating things, like who's going to facilitate. And so we have a meeting in a couple weeks to, our whole team will go there and learn about what we need to do. Each person will have their own jobs to do. And but I did want to make we do have 10 slots. So if somebody from the board, I mean, if that's something that we want to say, if their organization would like to go, I think we can provide that for somebody at the board if they would like to go. But that's where we're at so far. We have all the speakers. We have one keynote that we are still working on, but other than that, it's going to be really great. I hope everybody can make it.
PNWU is making phone calls. We got a call yesterday saying we've got slots open, and so they're making actual phone calls.
Yeah, they're really helping us advertise and market. We're going to do some TV, some commercials maybe, and some advertising on the radio a little bit, and some newspaper articles. We're working on those. So, yeah.
Just to add to that, if organizations want to do sponsorship, there's sponsorships available that would come with some tickets and some tabling opportunities, as well as some branding. So they are able to participate in that. The one keynote spot that we have open, originally we wanted to get Ken Crabell. We really liked him. And
we found somebody to talk on the same thing. Dr. Bilski did.
So we did get that filled.
Yeah, he's already contacted that person. They've already agreed, and so we'll talk about it tomorrow at our meeting. But yeah.
So we want to get somebody in to talk about what's called secondary trauma or vicarious trauma, which is picked up by caregivers, including providers, and talking about strategies for them to maintain balance as they act as clinical care providers to people who have trauma. So that's a really important part of this.
Yeah.
I think it's such a great example of the value of an ACH, because Benton and Franklin could not have done this on their own, but Yakima has the interprofessional group through the PNWU, which this is right up their alley. This is what they do. They bring cross-sector providers together for educational opportunities. And some of the speakers are nationally known. Some are state experts. So when we go to these webinars and we look at these people, it's like, oh yeah, they're going to come to our, opioid summit. So it's pretty amazing the kind of access that you will have with speakers. And we've encouraged them to stay during the whole time so that, because sometimes the most valuable learnings are those conversations that you have in the hallway, or you link up with that person because now you know that they're the expert, that you can bring them into your organization.
Can you talk for a minute about what's happening the evening before?
Sure, I'll let Diane.
I haven't heard a lot
about that.
Yeah, we have, it's a public, it's open to the public. There are three panelists. They're each going to tell their story of, they're either they were addicted to opiates and now have got treatment. One had been administered the Narcan and saved his life. And then the other one, I'm not sure, but it has to do with addiction as well. And then there'll be a keynote speaker to kind of address, we're hoping to address the whole thing as a whole. We're still in the process of trying to find that keynote speaker as a matter of fact. But I think that Melissa from PNW has that under control. And then we're going to provide dinner for the families. And then there'll be a time for question and answering. The school district may hold a health fair out in the lobby area, out in like the lunchroom area, but we've given that up to that's their responsibility.
Is that going to be at PNW also?
No, it's going to be at Eisenhower High School.
Yeah.
And
Eisenhower going to be doing the school, like getting families.
It will be, they're going to advertise it through, we have a flyer that will be going out, and then it also be, they have a telephone system. I don't know if the schools here do the same thing. They send out these mass texts to everybody that's there. Oh, come to the school night. There we're going to be talking about addiction or whatever we decide that we want to have advertised. But we're going to talk about that more on Friday because we're still trying to pin down the details for that. I've let PNW pretty much handle the evening night because they're in Yakima and it's really kind of addressed to the Yakima area. I mean, because anybody can go, but that's where our focus is going to be.
And some of the presenters for those tables are a little bit separate from what the intent of the summit is. They want to talk about things like vaping and marijuana, and all important things, but the focus of the summit is really on opioid use disorder and trauma-informed approaches to that.
I think in general, the committee felt that there needed to be a public component to the whole summit. And this is an opportunity to get the information out to the community, to do some pre-advertising actually for the summit itself. And I know Dr. Bilski is working with KNDA because the Granger community has their own opioid group. And they have had a vision of doing these telenovelas. So we're hoping that maybe they could do a telenovela during the public event. And I don't know if you guys know what a telenovela is. It's like a soap opera. Yep. And so it's very dramatic. And we just thought that would be a great way to kick it off. But we're still working on some of those details.
Yeah.
Great.
Has the flyers gone out through the LINs?
For the public night or for the opiate summit?
Both the conference and the public night, and also through the United Ways, because those are just like kind of traditional ways. I think that we could expand the reach.
So I know Keith said he's sending a flyer. He hasn't sent it yet for us to send out through the county coalition. But they were still finishing it.
It's a great,
but we haven't seen anything on the public evening. That's why I asked, and it would be great to have something for that.
We're supposed to have everything pinned down by Friday, so we can send that out and get the word of that out. The thing about the summit, I just want to point out, is that it's really going to be clinical based.
Right.
It's really focused for the providers, not so much the public. because that it's really education for them and on all these different areas. I did do a lot of research on most of these speakers and contacted most of the speakers. We did have help with Dr. Bilski has some connections, and so he did help as well. And we have a working committee that has been working on it. So a lot of work has gone into it. We really want to make sure that it's successful for, the public night as well as the clinical information for the providers.
And Sue Birch, the Executive Director for Healthcare Authority, is going to be kicking off day one. So we're really excited about that. Actually, Governor Inslee asked her to participate.
That's great, Ronnie.
So this might be too late to even think about it, but maybe future going forward. Is there any possibility of doing a live feed so that people can pick it up?
Well, we're charging for it, so not sure if we're going to have a live feed. We can record it, and we might we could put different sessions on our website. They have a program called Sketch, which is a program that everybody who registers will have access to, and they'll be able to get the presentations right there on their phone or their computers while they're there. Then after the fact, all the presentations will all be available. So the Sketch program is great because it'll tell you where to go. It'll have a map of the facilities and things that we went to the rural north. How do you say? Yeah, they had an app kind of like that, and this is a similar thing that we decided that it was worth the funds to do that. That way, people have access to it right then.
It really enhanced that app. Really enhanced the experience. All the presentations were there. There was a blog where people could interact with each other and communicate with each other. Network. It was really nice.
It was good. Great. Okay. Anything else on reports and updates?
Lauren.
Yeah, I'll talk briefly about the meeting this morning. At the Leadership Council meeting this morning, we had Leanne Turnbull from Aging and Long-Term Care present on Initiative 2, Long-Term Services and Support. And then we had Jacob Avery from AmeriGroup present on Initiative 3, which is Foundational Community Supports, Housing, and Employment. Carol also gave a brief presentation on the Supportive Housing Committee and our headway we're making with that. And then Wes gave a presentation on the ARM dashboard. And then we're excited to announce that we have received Chaplaincy Healthcare's end-of-life conference sponsorship application, and we went ahead and funded that. So we sent them $3,500 for their event on October 18th. The next application window opens 1st of July, and I know we've already actually received a couple of applications for the next quarter funds. So exciting.
Yep.
So were we able to access the CSI portal?
Yep.
Did you want to talk about CSI?
It's coming up after the track.
Oh, okay. So we can.
Yeah, you can.
So we broke the trackers down differently this meeting. So there's two of them. So Martine and I split the site. So the first one is my site that starts with CHCW and goes all the way down. And so just going across, it shows the dates when people turned in their workbooks, basically, that met all the milestones. You'll notice there's a lot of 415s on here because that was the due date. Yeah, so that's when a lot of stuff got turned in by people. We got a few people who did some things early, but as we move along, so at the end of every quarter, it's due. So you'll see underneath the 415, we'll just expand that cell and probably put July 15th for a lot of people, and we'll just keep going through the rest of the year. So, yeah, this is an update of just where each individual site is at. So, yeah.
And then the next one is mine. Just a quick update on the red line EIT across. That has changed. And same thing, there's a lot of 415 dates on there, due date. That's when they turn them in. So that's the date that goes in there. There's a couple of different dates in the beginning when we did the assessment, The BTAWs, those are a little bit different dates. So going forward, there'll be more dates added on there.
That looks like a lot of work.
Yeah, yeah.
It's kind of busy.
Well, yeah, on the top, it's broken down by milestone. And so for the columns that don't have any dates on them, those were quarter 2 reports. So next in August, when we have the next board meeting, you guys will see those columns filled in with some dates.
These trackers become very useful because of all the deliverables and all the providers involved.
Wow. Anybody have any questions about any of this? So, this might be, this doesn't matter, Charlie, but these trackers that we're looking on, do they relate to this green, yellow, red?
Yes. So those, that you're holding, the spreadsheet with the colors, that only highlights the 4 project areas that we have in ACH that we're taking out of the milestones.
So this is the milestones is the detail of the green, yellow, red.
Right.
But you can provide that to you, Rhonda, if you want to see the whole spreadsheet.
Not sure that I do. I just want to, it helps me to know how they relate. But yeah,
so
clearly it shows that.
We extracted that information from the workbook from the milestone.
Yeah, but the providers are really clearly doing a lot of work to transform, really, right? I mean, that's the purpose of this. And I think it's a really good indication that it shows there are people that are moving forward. Right? I mean, it's not, I guess the question is to you guys who are in the practices, is that what you're seeing?
Yeah.
Absolutely. Yeah, we have some sites who are just kind of going above and beyond. They're really taking the approach of having it be done by site versus by organization, and they're running with that. So rather than like a Providence who has a hospital and 2 clinics and all doing the same measures, like for their clinical quality measures, they ask each site, like, what do you see? Even though Walla Walla is fairly small, based on their urgent care, their primary care in the hospital, some of them have different metrics that they're going to be looking at and tracking and risk stratifying because their patient populations that they see are different. So, and they're really taking that and like spreading it and scaling it. I know for, who is it, Comprehensive, they're doing self-management as what they picked for practice transformation, but they're doing it at all their sites. So they're like, we might as well just go ahead and do it everywhere. So it's doing, practice transformation is doing what it's supposed to be doing.
Any questions or comments? Okay. Thank you.
Yeah.
I think we need.
Okay, I've lost this.
The LIN tracker.
The LIN tracker.
Yep.
Okay.
So I'll talk about this a little bit. I went over it briefly in the report as well. So this is the spreadsheet that's in the report comes from this larger spreadsheet. So this is just a little more detailed of where everybody is with their what I just talked about. They're all contracted. They've all been paid. It's just a tracker that shows that those monies are going out. Yeah, they're going out. So this was the LINs had a delivery due date of end of April. Sorry, I forgot what date it was. April 30th. Thanks. To get their first quarter deliverables in, and everybody did. And Ruben and I went through and looked at all of them, and we are paying Blue Mountain Regional Community Health Partnership for their first quarter in this payment this week. But the rest of them, we had some questions for them on their budget. A lot of them didn't have. We came back and asked them to show us what they, how they were gonna. If they didn't spend all the money from 2018, we asked them to show how they were gonna utilize it in 2019. So those agencies that we asked that they didn't get paid for, unfortunately. But we want to see. I mean, there's a lot of them that some of them didn't even know that they got money. I mean, it was like, oh, we got money. So I showed them pictures of the check. Yeah, cashed it even. So, so those organizations, I asked them to roll that money into their 2019 budget so we can see what they're going to do. So hopefully they do some good things with their money this year, and we get some good results from the lens. And Ruben and I've been going out, and it's been fun for me because I've been learning more about the lens. I think we talked about this before. Ruben's under my wing now, and so I've been going around to the Lend meetings with him and meeting all of the Lend organizations and introducing myself to everybody. It's been kind of fun. We've been driving all over the place. Some of those places are really far from here. Yeah, it's been a lot of driving, but it's been fun. I've learned a lot about what the Lends are doing, and most of them are doing really good work, and it's been fun to see. So anyways, that's what this is, showing you what quarter one reporting came in and who's getting paid. And moving on to the next quarter.
Thank you.
Yeah.
Cool. Okay. CSI portal and community overpage.
All right.
Community page overview.
So if Lauren wants to bring that up.
You want to see a community page?
Yeah, I'll start with the community page.
I want to do them.
So, we've talked about this for several months now. We've had a contract with CSI. CSI Solutions also contracts with, I think, at least 3 or 4 other ACHs, including Olympic, North Sound, and North Central, to create a community like this. They call this their community page, or the front end to the page, where practice transformation organizations will be able to log on. There will be folders listed here for each organization that will include the practice transformation documents, like their change plan, their contract, and other things that relate to their work. So it'll be more conveniently set up than the Dropbox accounts that we're using right now. And as you can see there, Lauren is the site administrator for this. She's got the boxes set up for our practice transformation organizations as they're laid out right there. And we've gone through some preliminary training. So
the training, since you said preliminary training, it just kind of keyed in. Is it on this too if somebody missed it?
So it was internally for the internal
okay.
staff, and then the practice transformation navigators, the practice transformation team will be assigned responsibility for training the participating providers on how to use the portal from their end and to be granted permission so that they can log on. Can you go to the web form? So what you're about to see is the piece that's taken a considerable amount of time and a lot of collaboration with CSI to create. It's based on the practice transformation work group, which all the participating providers know very well, which is linked to the toolkit. And so if you go on and you select an organization, these are still kind of in a test phase, and then select a time period, which we have as Q1, and then we select a milestone. As you know, there are 8 milestones, so let's go to 2, since that's the bear.
Yeah. It's like the longest one.
It is. It's huge. It may be as long as perhaps the rest of the milestones combined. This is what the form looks like. And so if you scroll down, you will see a lot of similarities between the way that the workbook is constructed and the way that the inputs on the form look like. However, the form consolidates a lot of those big page length or more than page length tables in some areas into drop-down boxes. So the provider organization will log on when it comes time to reporting their milestone deliverables. They'll go through here and input information. And for example, you'll see right there where there's a calculation. The form will calculate automatically once they save and come out of this milestone and come back into it. And it goes on for pages. It took quite a bit of development time and different individuals approaching the form from different ways to put this all together. For now, the practice transformation team, Sam has been assigned the point of contact who will interface with CSI. The team is going through and they're troubleshooting by meticulously comparing the forms, the forms they look here, the way they look here versus what they look like in the workbook. We want it to be relatively seamless, and the requested action in the workbook should be similar to what the requested action is here. So if you want to just go ahead and scroll down, you can see how long this particular page is. we don't necessarily have to go through the whole thing. Again, this is just one of 8 milestones. There was just a ton of work that was put into this. So far, we've been very happy with the way that it looks, although we have come up with some things that need change requests. And they'll be funneled again through STAM, who will be interfacing with CSI to make those changes. Once, Rhonda, do you have a question?
Just that, going back to my question earlier, so the milestones some of the milestones are slightly different for primary care versus hospitals versus behavioral health, and so this will be tailored to each of those groups?
We're going to figure out how to make that happen. Right now, this is pretty much the full meal deal of everything, which the practice transformation organizations are accountable. How we tailor that to those organizations is something that we have to deal with.
Is that the ideal? That's the idea that you're working toward?
It would be ideal to where if you're a behavioral health agency and we move to that process and they have a different set of milestones, when they come in here, it'll look different. But we're still trying to figure out how we're going to make that work. It may require. Yes,
Sam. Oh, I'm sorry. If you recall, he actually added where we could on the back side just to select different milestones if we want to bring them in or out. I don't know if it's operable yet, but that's what he was working on. So I would foresee that would be done immediately as well.
Sam, thank you so much. You're exactly right. I forgot all about that. There's a place in here where you can designate which milestones are tied to each organization. Thank you for bringing that up.
That's
great.
Dana?
Will if a provider has multiple sites, will they have to fill one of these each out for each site location?
Yes. So currently, that's how it works right now. So with Lourdes, for example, Shauna does a workbook for inpatient, or IMFT, and the hospital.
So there, copy and paste.
There's a good thing to that. Even though the sites, if they have multiple sites, if the data from Q1, Jenna and I will upload it to the reporting platform that will roll into Q2. So all you guys would have to do is go in and update any of the information that was provided.
That's the goal. We want to try to make, obviously this is a lot of information, a lot of accountability. We want to try to make it as easy for our participating providers as possible. So, yeah.
Cool.
So again, once we go through the review. Quiet down there.
She's going to be busy for a little.
I will share those. This is going to be way better.
Yay!
The reporting
The hand.
in my mind.
Yeah.
So there's
in your mind.
This is going to be great.
There's a big spend tied to this. We thought about this real carefully, and there are going to be some dashboarding features which we're not seeing today that will roll this up, that will give us a nice system view to where organizations are at, and it'll better help us identify where there's opportunities for improvement.
So is this going to be always open, or do you envision opening this for a certain period of time during the quarter, or how does this work?
Always open.
Always open.
And did you go to the resources page?
Yeah, I was going to say the community.
The other thing that we're hearing now is that the healthcare authority is getting more and more interested in specifics about which providers that our ACHs are working with. And so we're like way ahead of the game in terms of understanding which clinics are doing what and what measures they're working on. And the other ACH leaders are kind of panicking because they haven't set up any of the reporting to accommodate that. So we're just kind of lucky that we're ahead of the game in that respect.
Yeah, this is very cool.
It is, and once we get through the change request, then we're going to ask one of our participating providers to just put information in there to work with us to see how it works in the real world. And that may...
Is there a notification feature for like if a clinic or a hospital finishes their milestones? Will it notify the navigators? Is there a feature that does that? I'm sure. Yeah.
I know there is with the
Email or-
community page. So.
Yeah, I'm sure there is. Because you can, for the community page, if I'll be uploading documents constantly, you can subscribe to a certain folder. So if I'm uploading a document to the resources page, you can subscribe to resources and you'll get a notification every time I upload a document. Or calendar, the calendar feature also has a subscription option. So I'm sure there is an option to get notified. No, I didn't talk about that.
There's, on the landing page, there's a forum section, where, you know, if an organization has a question, they can post it on there, and other organizations are able to see it and give feedback on that question. And same thing if you register to get notifications for that specific question. When somebody posts something, you'll get a notification. So you
The
can go ahead
difference
and-
between the forums and the listservs.
I'm not sure what listservs are. Do you know why?
To be honest, the other ACHs that have used this haven't used the listservs very much, and we'll have to weigh the benefits and advantages versus what you're talking about. But in general, this is just, I mean, it's a great environment for collaboration, more so certainly than Dropbox has been.
So how did we get this?
We bought it.
And they just have to add whoever they want, we just add them by their email, right?
So, just forward thinking, I'm sorry, and I know that this is specific to this, what we're doing now. But in my forward thinking, we could recreate this for other, like if we're working with other specific agencies, that once we come out of all of this and we're rolling into the next phase of what the ACH is going to be, we could utilize this kind of thing working with other entities,
Yeah, absolutely.
recreating
We
it.
can afford it in our school too.
I don't know, that's what.
It's looking for grant opportunities.
Development director.
Yeah.
And an entrepreneurial.
Well, it was just a question because I didn't know if we had ownership of it, and so this answers my question. You
Yeah.
have to rebuy it to
We
reapply
would
it.
just continue it. We have a contract with CSI, so I think we would just renegotiate. I mean, unless I'm wrong. that's
We could
fine.
potentially do that. To be honest, this sort of blew up my HIT budget for this year because the development part of it literally tripled.
Yeah.
But the annual fee going forward, I think it's somewhere around $40,000 per year. So,
But the way that it's set up, Ronnie, is that, so this is the landing page, so we can send an invitation to anybody we want and say, hey, come look at this landing page that we have. So if we did move forward, we could use it for other providers as well.
Okay.
And then, like on the, I don't think we talked about the documents yet, but on the documents, like all of the Astria folders that you see there, only the people that we invite to see those folders can see those folders.
cool.
So it would only be.
well, I think everybody can see the folder, but you can't go.
You can't go into it,
You can't go inside. Yeah.
Okay, let's bring us back.
So,
I'm sorry, let's keep going. We got.
I think that's pretty much it. Again, the practice transformation team will pretty much have responsibility over the web form, and then Lauren will be the site administrator for this front end of the site with permissions and other changes.
Okay.
So
Great. And when do you hope to have this live?
June.
Okay.
I can't say June 1st, but it'll be in June.
So in time for the second quarter report?
Yes.
Okay. All right. Okay, thank you very much.
Bravo team.
Anything else? Wes?
Nope, thank you.
Okay. Let's go on to financials. I'm going to try to move us along here.
Okay, we'll be fast.
Okay. But thorough.
Okay, so the budget versus actuals is the document that I'm going to talk about mostly, but like always, you have the statement of activity, you have the statement of financial position, and you can always ask me questions or anybody on the finance committee. All right, Brian?
Sure. Again, we met last week,
You met, yeah.
and it was, we went through this stuff in detail. There were no outstanding elements in the statement of activity. We went through each of the points. I had Julie with me on the call, and we walked through some of this stuff in some detail.
We did.
Right? We
Yep.
talked a little bit about investment strategy as well. Becky and her team have advanced some existing investment policies being utilized by some of the other ACHs. So we're gonna go ahead and take a peek at that, because we think it's, we're dealing with a fair amount of money, we should probably have an investment strategy and should have a policy associated with that. So we will do that. I'm sure we'll talk about it in the next finance committee, and then probably bring something to the board.
Right, and so to expand on that, all the finance leads from the ACHs, we all got together in CTAC last month, and that was our number one topic, was sustainability and what the ACHs are doing to talk for that plan for themselves, and that correlated into a investment policy, and one of the ACHs actually has a resolution that's been approved by their board for their investment strategy, and so I think that's something that we could talk about, we should consider.
Yeah.
One of the ACHs has hired Charles Schwab Investments to do their investing for them, and they passed along some information from Schwab, because of course he was like, oh, there's 8 others of you? Yeah. They put together a little brochure, and I passed it along to Brian, and so some things for us to consider.
A couple of other little quickies in here, just from the accounting side. You guys cleaned up a little bit.
Yeah, Rachel's been cleaning up a lot
Couple
of
of the
our
accounts,
QuickBooks.
especially on the,
Yeah.
the employee liabilities
Yes.
side, right? The payroll liabilities.
They're all
So I
cleaned
think-
up now.
Yeah, everything's all
Yeah.
set. So it's a very good meeting. These guys have done a ton of work. They're able to answer all of our questions. It is wonderful having Julie, who actually understands this stuff really well.
Yeah, she does.
She's really good at this stuff.
She asked good questions.
She's a PTA.
Yeah, first Jorge and the rest of them are super additions to our.
Yeah, it's been nice to have.
I am happy to advance this as a recommendation.
The motion?
As a motion, yeah.
Okay, so I have a motion from Brian. Is there a second?
I'll second that.
Second from Ronnie. Is
Thank
there
you,
any
Brian,
further
for your work.
discussion?
Thank you.
All in favor to accept the financials?
Aye.
Hi.
Aye.
Who's the man?
It's been Dan.
Yeah, Dan.
Dan.
Oh, okay.
Julie's from last year.
He's still there.
Dan Ferguson?
Yeah.
Dan Ferguson, are you on the phone?
I am. Calling from
Thank you
Bellingham.
very much. Okay, thank you very much. Didn't know you were there. Okay, so we have a motion and a second. Oh, we've said aye. Are there any anyone opposed? Any abstentions? Financials are approved. Thank you all very much.
Thank you.
Thank you.
Thank you, Brian and Rick. Okay, so now let's go on to the EMS paramedic SBAR. So Carol or Diane?
Actually, Sam's on the phone.
Who's
She
gonna
said
take us
she's
through
gonna
this?
take it.
Okay,
Okay.
we'll let Sam take the lead.
Okay. There's so many important elements in here, so I'm primarily, instead of summarizing for the SBAR, there's a lot of detailed information that I'm going to highlight on.
Okay, Sam, get as close to the phone as you can, if you would.
Can you hear me?
A little bit. Yeah.
Okay, can you hear me better?
Yes.
So there's so much detail within the SBAR for this particular project, so there's quite a bit of information I'm going to touch on, but I will not read all of it, but the majority of it. The GCACH experienced high emergency ED visit rates among all the ACHs in Washington State. And we've been exploring approaches to this utilization and how we can actually fix it. One of those approaches is the community paramedicine program. And to better understand the usefulness of the community paramedicine program, its implementation locally, the GCH would like to support a pilot project with Kennewick Fire Department by supporting the implementation of the community health module available through ImageTrend, an IT vendor that offers electronic patient care reporting, which is EPCR, solutions to their EMS programs. The software would integrate existing patient data collected by the EMS through 911 calls and ED transports to highlight opportunities for face-to-face interventions with the community paramedicine within the patient's residence, with the result being to divert, redirect, or eliminate future 911 calls. The GCH would subsidize the cost of the $10,500 of the community health module to the pilot year number 1, and then subsequent to that, year 2 and beyond, then Kennewick Fire Department would take the responsibility for the ongoing annual licensing. The background to this is the community paramedicine is a relatively new and evolving healthcare model. The goal of these community paramedicine programs is to improve access to care and avoid duplicating existing services. KFD scheduled CP programs or community paramedicine program will focus on complex, underserved, and vulnerable individuals that exhibit a high 911 call volume that need an option or solution other than emergency room visit. The program will start with a small client base of individuals that exhibit high call volumes, meaning 5 calls within a 12-month period, identified through Kennewick Fire Department's existing electronic patient database. The community paramedicine will also track and analyze community paramedicine program summary data to determine the program's effectiveness and the need for wraparound services from within the community. Currently, Kennewick Fire Department, as well as most of the EMS fire departments within the GCH region, use ImageTrend modules as their patient electronic medical record. ImageTrend software is being deployed by many EMS providers nationwide, i.e. California, particularly. As an EPCR solutions provider, they've processed more than 180 million pre-hospital patient care records. Their community health module for community paramedicine has been successfully implemented in states throughout the country, and the module has shown to reduce 911 calls and ED utilization with patients that were enrolled in the associated community paramedicine program. The module is a complete solution for community paramedicine programs that allows EMS providers to use patient data that has already been collected through the ImageTrend primary EPCR. Using that data, community paramedicine programs can identify appropriate candidates for in-home interventions and includes a validated point system, which objectively identifies those individuals that would best be served as a community paramedicine program. In addition, what is not included on here is that this integrated model allows the EMS providers to see non-transported visits to the ED that they had previously did not have immediate access to, as well as the majority of the Greater Columbia Fire Districts could, I think there's 2 particular fire districts that could be transitioned over to ImageTrend as well. So each one of them would have the exact same EMR system. So the analysis, again, KFD, Kennewick Fire Department, has the largest 911 call volume of any fire-based EMS organization in the entire Mid-Columbia region, which would make them a great candidate for a pilot. In 2018, they responded to 6,639 EMS patient contacts and continued to see an increase in inappropriate 911 calls and transport. Although it's difficult to put an exact number on the percentage of the patient transports that could have been managed more effectively, since Washington state law requires EMS to transport only to emergency rooms, EMS organizations have limited options for patients with less than emergent concerns. Kennewick Fire Department is researching different ways to address these problems. And again, community paramedicine is one of those options, which they will be hiring someone in July of 2019. Kennewick Fire Department reported that in 2018, 1 out of every 4 patients contacted by Kennewick Fire Department was a repeat patient, which is defined as any patient who had called 911 3 or more times in a 12-month period. In 2018, 371 patients accounted for 1,685 of those calls, or 25% of Kennewick Fire Department's total call volume. There are 2 charts that are created from the data extracted from Kennewick Fire Department's electronic patient database. They indicate the distribution of 911 calls in 2018. The first chart groups individuals into the number of times they called Kennewick Fire Department 911 in 2018, i.e. 52 people called 911 5 times in 2018. The second chart indicates the total number of calls tied to those groupings. Individuals who called Kennewick Fire Department 911 5 times in 2018 made a total of 260 calls, and those are the individuals that would be targeted for this particular program. Data for individuals calling Kennewick Fire Department 911 1 or more times during the 2018 was excluded from this particular chart. From this data, it can be seen that the vast number of callers made 5 or fewer calls. However, there was a small group, 42, that called 911 7 or more times during the study period. This small subpopulation might be ideal for increased care coordination for CP intervention. The table indicates below calendar 2017 ED visits per 1,000 data for those major age cohorts across all ACHs in Washington state. Across each cohort, GCACH has the highest ED utilization among any ACH, and you can see that we come in at ages 0 to 17 at 52.85%, ages 18 to 64, 86.62, and then ages 65 plus, 87.51, which is much larger than any of the other ACHs. The GCACH improvement target goal for 2019 chart is the pay for performance metrics, all calls emergency department. And as you can see, the GCACH with our baseline numerical values and then the GCACH target rate. And so there's a significant increase that we need to be able to focus on. While these percentage reductions appear small, they correspond to a total visit reduction of approximately 3,300 visits across the GCACH for 2019. To meet its large ED visit pay for performance targets, GCACH will need to implement a number of different strategies. Accordingly, GCACH supports its local community paramedicine programs as a means to address their inappropriate use of the 911 services and resulting transfers to the ED. The recommendation is GCACH recommends the Board of Directors to approve this $10,500 for the district HIT budget to fund one-year pilot program to integrate ImageTrend's community health module into the KFD's current patient medical record system, which would support their emergency community paramedicine program.
Eric, do you have anything to add to that?
No, Sam, good job. That was very thorough.
Thank you.
You're certainly not using the program right now.
No, well, this is a module that is added to the existing EMR.
So could you maybe describe what it will do for you that you don't have now?
So, right now in our system, we can take down basic history, medical, surgical history, medications, allergies, things of that. All of it is ICD-10 compliant, and you can hold that basic information. The way that it's built, because it's 911 traditionally goes out, obtains the history from the family, the patient, the friends, the whoever, they insert it, and it's only relative to that particular event that day. What this new module permits is for the individual at point of care to be able to reach out and pull in more data that is stored within the database. This information would have to be still collected manually. There are other fancier bells and whistles out there that can integrate directly bidirectional data flow. That's not what this is. This would be the community paramedic going to point of care, pulling in all that data, having it there, and then being able to obviously refer to that data and add to that data as they continue to work with the individual.
Okay. Carrie.
So, someone calls 911, the paramedics come out, and they can either treat on site or go to the hospital, right?
Mm-hmm.
After that, the paramedics go back and collect more data from the families?
No. At that moment that they're there, they collect whatever information they can regarding this individual. Okay. Our current system, the way that it is, if we've been on the person before and we've taken in their medications and their history, and when they put in the name, they didn't miss a digit or something and create a new duplicate record, and it finds them, okay, great, then we can pull that data in from before. But again, it's minimal. I mean, it's their medications, their history, their allergies, and their name and date of birth and their address and phone number, and that's pretty much it. You know, and then when we ask them, okay, so, you know, you have this current diagnosis of congestive heart failure, you know, whether or not they told us or not, they also have diabetes on top of it, or COPD, or renal insufficiency, or other things. It's only on what they remember to tell us that day. So this addition would allow us to see the whole picture of what their true diagnoses are, as well as other treatment plans that have been there.
How does that reduce emergency room visits?
So what we're talking about doing here is, when we have somebody who's, so to back up, when we go out on somebody who's called 911, we have, like you just said, one of two options. We can either treat them and take them to the hospital or leave them where they are. I mean, it's that simple. We can't take them to their primary care physician. And even then, more times than not, because there's no good relationship there, once in a blue moon, I'll call a patient's physician because maybe they just left there an hour ago and they tell us that. Even then, sometimes the PCPs will be like, just take her to the ER. You know, what this would enable with the community paramedic is to actually be able to spend the time to sit down, to drill into the situation. Why is it, she doesn't understand her discharge plan that she was provided, or she hasn't received, she never got to the pharmacy to get to the medications that she was supposed to have when she was discharged 2 days ago. 911 ambulances don't have the time to spend, and they don't have all the tools necessarily. You know, when somebody gets discharged from Trios 3 hours ago, the only way we might know is that there's a band on their wrist. I mean, it's amazing what people don't tell you that you think would be germane. So this would hopefully help us pull all that together. So, yeah.
So your current system does not retain history, or it does?
It does. But like I said, it's very generic, and it's
so this is more.
And it's only
It's the hospital data.
it's the hospital data that we will be able to pull in through some other mechanisms to put in there, and also this module will also enable us to add form type scan documents to it that that the community paramedic would be able to reference. That's not data that you necessarily want every EMT and paramedic, and not that they can't be trusted. I'm just saying it's not stuff that you necessarily want everybody having access to.
So would all of your, and pardon my ignorance here, are all paramedics in the Kennewick Fire Department considered community paramedics, or is that a different classification?
It would be a different classification. Well, for one, it would be it's a day, 40-hour-a-week position in which using the scoring module that ImageTrend has within it, you identify it would seem reasonable to say, if we can scroll up on the graph, man, let's go after these individuals where, you know, one person, scroll up a little bit more, one person is responsible for 23 ambulance calls. Well, those individuals, we tend to find the behaviors are set. They're very difficult cases to deal with. Whereas what we believe and what ImageTrend's data shows nationwide is it's probably somewhere between the 5 and the 11, that those are the individuals that you can actually, for lack of a better term, I'll just call the low-hanging fruit, that is sometimes very simple. It's a very simple thing. Maybe the reason why their medication isn't working is because the doctor doesn't realize they don't have any protein-based food in their refrigerator. It's all carbohydrate, and if we could get them on a more appropriate meal plan, maybe the medications would work the way that they're supposed to. I mean, maybe I'm oversimplifying here, but these are the kinds of things that the community paramedic would be able to spend the time with admittedly, a limited number of individuals, but hopefully the right individuals to provide them the level of care they need in the home. Yeah.
So,
Jorge and then Rhonda. Jorge and then
I understand there's information shared with the hospital, so there will be actual information about the members shared with the hospital.
Yes, there would obviously have to be business agreements in place and things of that nature.
How about with the primary care provider? How does that information, of the work that you guys are doing for that member, for that patient, gets to the direct healthcare provider? Good question.
It's a great question.
We've talked about adding pre-managed visits somehow as well, but that's something that would have to be worked directly with ImageTrend with.
It's just when we talk about community paramedicine, it's important to have that full triage connected, because if it just becomes a relationship between paramedicine and ER, it can stay there forever and never get to the actual provider.
And that's obviously the ultimate goal,
Mhm.
is that it's not just with the emergency room, that it is with the PCP.
What would need to happen after this works and delivers initial reductions?
Well, but inevitably, if it goes to the ED, the PCPs are gonna tie into the EDI.
So they would.
I mean, it may not go from the paramedics.
There's a
but
scenario where they will not need EDI because hospitals have EDI, you have EDI.
That's what I'm saying.
Yeah.
Is that as long as the PCP has EDI, the hospital is
I
there. So
was sitting here thinking through the electronic health records. I mean, it would work for, provide physicians who are linked to the hospital per se.
the only person that's on the
Right.
loop is the community
Right.
paramedic.
And disconnect.
Or a
them.
private guy who's not somehow.
And that could-
Close.
So Ronnie.
So my question is, and
Great question.
this is part of what I was going to talk to, but, or speak to. But the other thing is that you're doing this instead of the, more integrated system, and the question is why? If you're gonna set it up in a way that you eventually gonna need that other piece, why would you go this route and not the full-on route to have a bigger, better, faster machine?
Well, this piece is going to be important no matter where. I mean, ultimately, you're absolutely right. To have an integrated HIH, which ImageTrend is capable of doing. They have HL7 interfaces and all of those things. They can, in fact, that was one thing we talked with them about, and when we got done choking on what the number was, we said, okay, well, let's eat the elephant one bite at a time. This piece is still going to be important because it is able to gather, or I should say, maintain that information in one place that's still important to this equation, and that is ED utilization continues. Contacts continue to happen. So when the paramedic shows up to Ethel's house, okay, they would be integrated into that would be also the EMS connections that they've had. You know, so I understand you called 911 last night.
Right.
What was that all about? And they'll, of course, get Ethel's story, but they'll also get to see the objective story provided by the paramedic
Right.
on the scene that night. So this piece is still going to become important whether we go the full meal deal and the HIH integration with the hospitals or the connection with.
So how is this going to, so I guess the question I have is that, okay, so this is viable, I understand that. This is the less expensive of the two, apparently.
Well,
But is it buildable to that?
Yes.
Okay.
Yes.
And
The first step.
what would be the next expense in that?
So existing already today in the system is a system that's referred to as Hospital Hub.
Right.
ImageTrends data electronically shows up in the Hospital Hub for whatever hospital the patient was transferred to. At the moment, Trios, Catholic, and Lourdes have to manually go in and grab that PCR and download the PDF into Epic or Allscripts or whatever it is they use. ImageTrend has already in their repertoire, already developed, already used in some places in the country, the expansion of that HIH to either automatically dump that record into Epic or Allscripts or whatever. And the third step, which would be to provide the bidirectional data feed, so that when the medic goes out there, he identifies that this truly is Ethel Jones, born on March 3rd, 1922. This is her social security number. And now, boom, we're linked, and we all know we're talking about the same person.
Right.
That is obviously a much bigger thing. We believe that we can begin to impact these numbers without that connection to start. And we think we can do that with this community paramedic module that will enable us to pull those records in manually, albeit.
But eventually upgrading is going to be.
Well, ultimately, but I think first of all, we have to have proof of concept.
Right.
Number two, we have to find willing partners. I can tell you, there's not a city council member, okay, because we're talking about municipal fire departments for the most part, or council or county commissioners. that are going to say, why do I have to pay $100,000 a year or whatever for a software for an MCO or a hospital to save money? Right? I mean, that conversation happens somewhere.
Sorry, we love you.
So I'm just putting that out there.
We have several community paramedicine initiatives in the state. This is very natural, and MCOs will be ready to support it as soon as the numbers.
Yeah, part of what you're putting up is a new FTE for a community paramedic.
Yes.
And you have the resources to do that.
Yeah, we actually just hired 12 new firefighters.
Okay.
9 of those are going, well, all 12 of them are going to the line, which is permitting 3 others to come off the line, and one of those positions is a community paramedic.
Okay. Okay.
So the program is already working. This is an additional piece of software you need to produce this specific.
Yes,
output.
we've been using Image Trends since the summer of 2017.
And is the 10,500 a one-time cost, or is it an ongoing?
It's an annual cost for that module.
It's less, it's $100 less than that for the annual fee.
Right.
Oh, 10,400.
Yeah.
No.
It's $1,000.
9,000.
Yeah.
9,000.
I'll buy 0.
But once we create concept, the good thing is that ImageStrike can go to the hospitals and say, hey, look, this is working. Do you guys want to contract with us? And they can make those connections where.
Okay, then Brian, it's in your lap. No, okay. Okay, so let me just ask if there's anybody on the phone that has any questions. Okay, everybody's good on the phone. So Ronnie, last question on this topic.
I promise. I'm so sorry. So it just sparks that community health worker in me, because we're talking about follow-up, we're talking about that futuristically looking. Is there going to be placement for community health workers to be involved with that kind of follow-up work?
Great question. I would answer that question that we will be absolutely flexible to what is best for Benton and Franklin, or for the Mid-Columbia. And the reason why I say it is this: in 2016, there was a community paramedic conference in Seattle.
Mm-hmm.
And the keynote speaker that spoke on the first day said something I will never forget. If you have seen one community paramedicine program in this country, you have seen exactly one community paramedicine program in this country. They all are different. There are ones that use case management. You know, there are some that use RNs. There are some that use PAs. Lots of options. I will commit right now that the Kennewick Fire Department will remain flexible in determining the best way to move forward and integrating what is best for our region and the way our systems work here. We have so many resources around here. Sometimes you don't need that. You just need somebody to show up there to Ethel's house and tie her into those things.
That's what I'm talking about.
You know,
DHWs do that work.
Yeah.
Okay, so we have a recommendation from the staff. Has everyone heard enough to feel like they can make an informed decision? Okay, would someone like to make a motion?
I like the motion.
Terry? What are you?
That we support this
The
at the
staff
10,500.
recommendation? Okay, so I have a motion from Carrie to support the staff recommendation. Is there a second?
Second.
Second from Dana. Is there any further discussion? All in favor?
Aye.
Anyone opposed?
Aye.
Those were in support, correct? Phone people?
Wait 10 seconds.
Yes.
Sorry, I went too soon. Okay. Is anyone opposed? All right. Are there any abstentions?
I abstain.
Okay. One abstention. Thank you. Okay, motion approved. Thank you. Great discussion. Go forth and do good things.
Thank you.
Okay, we'll look forward to your report, probably a mid-year report or something.
Yeah.
So, okay, great. Great research from the staff. Thank you all very much.
Diane.
So we have a report from the Community Resilience Campaign Task Force. Becky?
So this is a charter for the Community Resilience Task Force, and Ruben has been working very hard on this, and a lot of this started before I got roped into his job, and so I
Roped in?
Well, no,
That's fine.
You're gonna take garage.
He tripped and fell into it.
I know.
You think a different word.
I was gonna say is maybe Wes could help me.
It's okay. We're just.
We hear you, Becky.
We love you, Becky.
Becky is our,
Anyways,
we're going to spend a lot of time on this.
he did, and a lot of work went into this before I came on board is what I should
There you
have
go.
said.
Nice recovery.
What I do know about this, though, is this started as an ACES campaign, and there were $600,000 that we all approved in the budget for this work. And since then, the task force has come together, and Ruben and Wes has done a lot of work on this, and the decision was made to not focus on ACES, and so at the last task force meeting, there was a vote to call it the Community Resilience Campaign Task Force Charter, which is a really long acronym, but that's where we're at. So we're at the CRCTF now. So Ruben wrote this task force along with Wes and I and Carol, and we also put together a small group to kind of focus a little bit because the charter group is huge. I don't know how many people are on it. 26, a lot. So we put together a small group of about 5 people, including the GCCH team, and we went through and we came up with a definition of what a resilient community is, and we put together this purpose, and we put together the responsibilities of the charter and the responsibilities of GCCH. We pulled in some of the kind of high-level stuff, administration duties, and our conflict of interest statement, reporting, and all those things that we've had in other charters. So you guys have seen some of this language before. I specifically took stuff out of the Practice Transformation Work Group charter because I think it was a good one. So most of this won't be too unfamiliar to you. But the purpose of this task force is to identify the focus areas, target populations, and strategies and measures of success to build community resilience that will translate into individual resilience. So the task force is a group of
Subject matter.
I kept saying SME in my head, and no, what does that mean? Subject matter experts that are going to bring together what their expertise in their groups and their communities and their fields, and we're going to hopefully have some good outcomes and spend some money on some good not programs. We changed it. We programs and change it to initiatives. So we're going to fund some initiatives, and the task force is going to help us identify those. So this is just the task force charter that we're asking the board to approve so that we can move forward with this work.
Did you want to talk about the stipend?
Well, I didn't know if you wanted me to talk about it.
Well, it's in the charter, so we should point it out.
So, okay, so with some of our other groups, we have offered a stipend. As you know, we offer a stipend for the board. We offered a stipend for the Practice Transformation Work Group. So we put in here that the task force would receive a stipend, but we haven't decided on what that would look like. Right now, they're meeting monthly. Ruben's recommendation, which I'll pass forward on to you, was that for each meeting, the attendees would receive $100 that we would pay quarterly so that we weren't paying out more payments than we already are every month. So just to kind of save on some administration from our side. So that was Ruben's recommendation. Carol, do you want to have a recommendation that's different from that? No. So that would be the recommendation, is that for every meeting that they attend, they would receive $100, and Ruben would keep track of it, and we would pay them quarterly.
And I think the reason behind that is that the quality of the people that are on this task force are very high level, people that are pretty well known across the state for work being done either in ACES or trauma-informed care. So Terry Barilla, Carla Kroc, Thatcher Felt. There's, he has some really great people that are working on this so that they're expending time away from their jobs to help promote this kind of an idea. We don't know what those initiatives are actually going to look like. It could be a messaging campaign, similar to kind of what we saw with ALTC today. But we're letting them take the lead on that. But we were really focusing on community resiliency as opposed to individual programs. Like, we're not focusing on strengthening families or communities in schools. Those are programs that our communities deliver. But what makes a resilient community and what is missing, is what the focus of this group would be doing.
And it was less about ACEs, because if individuals went out and tried to self-diagnose, it just
Right.
might re-traumatize people.
Right.
And Rhonda's part of that group and part of the subject matter experts as well. So it's a formidable group.
Well, if Rhonda's on it. then- Okay, so have people had a chance to look at the charter?
Yes.
Are there any questions or comments about the charter?
Any ballpark estimates on what the stipend could add to?
How many people would get the stipend?
It was 26, is that what?
Yeah, I believe that my count was like 26, but I haven't been able to make a meeting because I have,
26
a
times
Friday
how much?
meeting
100.
that I have to be at.
Yeah.
Yeah, per meeting. And so, and another thing, it's okay, Ron.
Is that monthly amount?
Yeah, so they're meeting monthly right now. Yeah, they're meeting monthly right now.
They're meeting on Friday monthly.
Not everybody's gonna attend every time, and, you know, some of the other, charters, we've paid them, like, at the end of the year, as just a one lump
Flat,
sum
yeah.
for attending the meetings. Ruben wanted to, his plan was to pay them each time they attend, to try as an incentive to come. So, and I support that, so.
And I'm
That
not
would be
sure
a
that all of
recommendation.
those people are still on that. I know that.
There is a lot, I think
There
you're
is a lot.
close. I was gonna
Yeah.
say 30, so I think you're pretty close.
Yeah, I'm thinking that
It
my
says
last.
at least 15 in the charter, so I'm,
Maybe a little over 30,000 if everybody is.
Who ultimately drives the agenda of
and he has
the
a
task?
pretty
So
good
the task
budget.
force
It's a
selected
massive
two
budget.
co-chairs.
Yeah, so
Okay,
it'd be
let's just
Ruben.
narrow it down to one conversation.
So Ruben runs the agenda and he nominated two co-chairs who accepted the position at this last meeting. So the three of them would work together on the agenda. And then we weekly, we meet with Ruben and talk about the task force and the work that they're doing. We meaning me, Carol, and Wes, and we went over the agenda with them before this meeting, and so we all are having input, but Ruben and the two co-chairs would be the starting points for the agenda.
Right. That's a question, Madam Chair.
Yes.
Would we be voting for this to be a permanent task force from now until the funding sunsets, or for a year? Or for how
No,
long?
so it's 2 years. So the $600,000 for this task force was put into the budget for a 2-year project.
So we replace those $600,000 with,
So this is.
Well, that will be up to the next year's budget.
Yes, yes.
yes.
Mhm.
So the first, by definition, typically a task force has a time limit.
Mhm.
Yeah.
So the task force is for 1 year, for 2
2
years?
years.
For 2 years.
2 years.
So first question is about the charter itself. Let's talk about the charter itself. Are there comments or concerns about the charter? Okay, let's start with the charter first about, would someone like to make a motion to accept the charter?
I'll make the motion to accept the charter.
Is there a second?
I'll second.
Second by Eric. Is there any further discussion on the charter? Okay, all in favor?
Aye.
Anyone?
Aye.
Learning. Is there anyone opposed to the charter? Is there anyone abstaining from the charter? Okay, so we've accepted the charter. So now let's talk about the stipend. There's been a suggestion from the staff that we have a stipend of $100 per meeting.
Per person per meeting.
Per person per meeting.
Per organization.
Per organization.
Oh, okay.
Thank you for the clarification.
Yeah.
So let's have some discussion about that.
Is there, what's the process of getting those organizations chosen to be
They've already been chosen.
on the task force? Did I miss
It was
that?
open
It's
to
open.
anyone who wants, right?
So anyone
It
who
was
wants
open
to-
with, Ruben came to a meeting, he asked all the board members to make recommendations and nominate people to be on the task force, and so that's how those nominations happened.
And they could be self-nomination.
Yeah, they could be. So, I was making recommendations and he had asked me to come on as
Okay.
well. And I told him that if I could make the meetings, I'll be there. At that time, he was trying to get as many people that knew about ACES together in
Right.
one setting. And then from that, people made a decision whether they were going to stay or leave.
That's true, because I do think that Dr. Fell contacted us and asked us if he could be on the task force, but given his work as a child pediatrician, we felt he would be a great addition to the task force.
So, and I think that it was well done because he was very collaborative about the process that he was trying to get to. And I felt that the people that were coming on board were very, very astute in the ACEs and what the need for the community was.
Plus, they're all through the region.
Yeah,
Just
they
one
are.
area. There's Buxton. There's somebody
there's
from
a lot of people from all areas.
And if someone else, next week called and said, I'd like to join this task force, would there be anything that would preclude them from joining?
I don't know. I mean, I think that you have, at some point, you have to limit the number of people that are going to be in a task force. It's pretty large as it is.
I think probably.
I would
And
say
I
only
think
if there were certain holes in the region that we needed to fill, but I know that there's representation from Kittitas and Yakima and Walla Walla and Stoughton.
And if I'm not mistaken, I do believe that he sent out something that said at this time we're going to close it or something, or respond by this date. And I think that was like after that he wasn't going to accept any more persons to come on board. So, but they are pretty full. So I don't think that he's put out that he's looking for any more.
Okay. So, any other recommendations regarding the stipend? Any comments on the phone?
I'm wondering if you got 25 people already on it and you're turning people away, sort of, maybe you're not turning people away.
Sound like it.
I'm going to answer my question. So, why do I have to pay people to come to a meeting that you got 25 people on the committee? Just a thought. I mean, if it was.
Probably equity to the other committees.
Yeah, that's right.
Yeah,
I'm okay with that.
So you want to make a motion then?
Yeah, so make a motion that we go
Move
ahead
things
and
along.
provide a stipend for the organizations that are supporting or that are on the task force for
100.
all of these letters.
Community Resilience Campaign Task Force.
That's the one.
And are you recommending the $100?
And I recommend $100.
Okay.
Just so I can staff it. They're so smart. It's good.
Is there a second?
I'll second.
There you go.
Second from Ronnie.
Thank you.
Is there any further discussion? Okay, hearing none, all in
Bravo.
favor?
Aye.
Aye.
I didn't hear anything on the phone, so I'm now going to say, is there anyone opposed? Are there any abstentions? Okay, motion passes. Thank you. Is anybody getting a little warm?
It is.
What's going on?
I just talked to them, I asked them to turn the air on.
This is just a second, separate motion.
Yes,
Not
there-
the charter itself.
Yeah, there were two
Okay.
separate motions.
Okay, just to
Okay.
make sure it wasn't an updated version.
Is there anybody here that's on that task force?
I am.
I am, but I haven't been able
I didn't
to
vote.
make the meeting.
I never vote unless it's a tie.
Well, then, should anybody getting paid have abstained, I guess is my question.
So Ronnie can't second
Probably.
it.
Oh, good point.
But I haven't been to the meetings and I haven't been able to be on board. So I don't
Okay,
think that I'm really there.
If,
So,
okay, would somebody else like to second it that's not on the task force?
Okay.
Okay, good, thank you,
Thank
Carrie,
you.
for pointing that out.
appreciate that.
Okay, so nobody else was opposed, so I think we're still good. Thank you for calling that out. Okay, we're going to move on to the mid-adopter funding allocation, SBAR. This is Carol and Diane, so who's going to start it?
I will
Carol.
start it. So, For the new people that have not been familiar with what a mid-adopter is, way back in, I think it was in 2004, the state of Washington declared that the BHOs would have integrated managed care. And they started out, oh my goodness.
2004 or 14?
No, I think it's been at least 10 years that the Healthcare Authority made an announcement that we were going to start integrating services. And they started with integration of mental and substance use.
Right.
So what that meant is that the managed care organizations, instead of the behavioral health organizations, would be administering those funds. The BHO, the Behavioral Health Organization in our region, is called Greater Columbia Behavioral Health. And so it was a very big task for them to do that integration. Following that, then, the state declared, now we're going to integrate primary care and behavioral health all together. And that started really in 2014. So this initiative has been going on for quite some time. And as part of the incentive for what they were called the regional support networks, the RSNs, as part of that initiative, regional support networks were incented to integrate these services with managed care organizations, and each ACH then became the same contiguous boundaries as the RSN. So that's how we ended up with 9 counties, is that our boundary lines imitate each RSN across the state of Washington. That was a legislative decision. So even though Whitman County did not want to belong to our ACH, they were forced into it by virtue of legislation. So fast forward to Greater Columbia BHO, who reluctantly, albeit, signed a letter of intent to become a mid-adopter. And that set in motion this process that's called behavioral health incentive payments. And as a reward for being a mid-adopter, because there have been 3 phases to this now, there was an early adopter, there were 2 ACHs that became early adopters. A group of us came on as mid-adopters, which meant that we had to integrate services by 2019. And then there are 2 remaining ACHs that kind of got left out in the cold because their RSNs didn't vote. There was money on the table to help these providers transition to a managed care system. Not all of them were set up to send or receive Medicaid claims and data. So this incentive that was provided last year was for $4 million. Those funds then were distributed to all of the community mental health, behavioral health agencies in our region. There were 17 of them under a formula that the BHO decided. So the board of directors, even though they had the authority to determine what that funding allocation might look like, they allowed the provider group to make that decision.
Which is this in the packet.
Okay, so Diane is referring to the distribution that was made to the behavioral health organizations in 2018. There are 2 phases of the behavioral health incentive funds. The first one was for that binding letter of intent, and then phase 2 related to certain milestones that each ACH had to achieve in order to receive the next set of milestones or the next set of payments. That next set of payments was $6 million. And that $6 million then now is on the table for discussion today in terms of how that fund should be allocated. So we have had an opportunity during the past year working with the behavioral health organizations, because our practice transformation navigators actually were part of the process to help the behavioral health organizations get ready for managed care. Through those discussions, through staff discussions, we were trying to figure out what is the best way to allocate that funding. And we've had on and off discussions during board meetings about how that funding should be allocated. And so what I tried to do in this situation piece for those new board members was to highlight some of the things that we heard from the board members about the funding distribution. So I'm going to refer to the second set of bullets. So that
on which sheet, Carol?
Okay, now I'm talking to the SBAR.
So this is what's on the screen.
Yes. And the second set of bullets were some of the recommendations that we heard coming from the board. That they would make the recommendation for the phase 2 budget. with input from the provider readiness group, that there would be milestones for the phase 2 funding. The funds would be distributed not based on the behavioral health organization formula, which was really driven by the BHO, and honestly, we never really understood how they came up with their funding formula. We just knew that there was a formula that was presented to us. It seemed like a lot of it that was based on the number of Medicaid lives. That the funds would be distributed to the same 17 behavioral health agencies that had received the first set of funds, and that when we passed our budget, our district budget in 2018 in December, we had assumed some funding set aside for the ORNs, technical assistance. That's how we got some money for the behavioral health scholarship or internship funding, and perhaps some community health worker workforce development.
And go back and remind us what ORNs is.
Opioid Resource Network. So with that in mind, then the staff put together a budget, and I'm going to take you to the second page now, where we have laid out what we think would be a good use of that $6.1 million that we received. We took this budget to the provider readiness group just on Tuesday, and there was quite a bit of discussion about the allocation for the behavioral health organizations. But for today's purposes, what we'd really like to do is to talk about the budget and the allocation to the organizations, and then we can show you how we broke down the integration incentives for the 17 organizations, which was really based on practice, the patient-centered medical home milestones that the organizations are now receiving.
So that probably goes back to my question earlier. So this lines up with the grids that the rest of primary care providers in the hospitals. Is that what that first integration is, in a sense?
Yes.
Okay. That's helpful to put that all together.
With some exceptions.
Yeah, with a few exceptions, because behavioral health organizations might not have all of the same sets of milestones, and so SAM and Practice Transformation Navigators went through the milestones to say, does this milestone really apply to the behavioral health organization?
Just like you did with the hospitals.
Right. But with the idea is that the primary goal of the Medicaid Transformation Project is integration, bidirectional integration. And that is because it works, it brings down costs, it's better for patients when you can integrate those services and patients aren't, lost through the cracks because the referrals are not, being followed up on. So bidirectional integration by far receives the most amount of money from the state because it produces the most amount of efficiency. So with that in mind, that's why we really lean towards having behavioral health organizations, go through the practice transformation journey like our providers have, because those are the tools that they need to be really efficient. They create these relationships, they integrate, and we've seen it already happening, but we'd like for them to continue on that journey. Now, some of the providers had a little bit different ideas on how those funds should be distributed. We're not going to, deny that there was some disagreement about how those funds should be allocated. But primarily, I think that we've heard even beyond the meeting venue is that a lot of behavioral health providers are ready to take that next step in terms of integration.
So before you go further, I just for background. So in terms of the percentages, we have a budget and funds flow committee.
Yes.
So did the percentages, and I know Darlene's on the phone, and I don't know who else is on that committee, but did the percentages come from the budget and funds flow committee?
No, it was an analysis that we did just to take a look at. So how does this, after this meeting that we had, how does this really compare to the PCMH organizations? And what we can tell you is that the percentages actually for behavioral health organizations are somewhat higher. But that being said, we felt that the fairest way to lay out the milestones was to have them similar to what the PCMH organizations are being required to do. I think some of the behavioral health agencies felt like that they shouldn't have any milestones, that there shouldn't be any requirements on any of the deliverables, that they should just be simply given the money. But as you can see from our discussion today, nobody gets a free pass. Everybody has to report. Everybody has milestones, even our scholarships that we give out, or our sponsorships, they have to report back. So we feel in order to be a good steward of the GCSH funds, that there needs to be milestones and accountability attached with each one of for the behavioral health organizations, because they're receiving quite a bit of money. So
there's a supporting documentation in the back as well. The expectations regarding the use of the Medicaid transformation integration incentive funding is really an important document to explain what the funds should be used for.
It's actually part of this document, regional funding sources.
Actually,
No,
it
it's
wasn't
separate.
it was a separate document.
Oh, it
It
was.
wasn't.
So that supports it as well.
So we've supplied the board with these documents from the Healthcare Authority, because I think that there are still some providers, the behavioral health providers, that feel that these are their funds and that the ACH really shouldn't be dictating how those funds are to be used. But clearly, our guidance from the Healthcare Authority tells us that, yes, it's really the board's fiduciary responsibility to allocate those funds how they feel would be the best use of them for the region.
Well, for point of reference, again, I know we have a couple of new board members, but we've had this discussion with the HCA before.
Yes, and so we also
it's the-
supplied this email. So this is an email that I had put in the packet for a previous decision for the behavioral health organizations in August. And it was between myself, Isabel Jones, who then was running the mid-adopter program, Chase Napier, who's with Healthcare Authority, Kelly Klein, who is no longer with Healthcare Authority, but she was the financial policy person, Ed Thornbrood, Danica Gwynn, and then Diana and I were on this call. And really the heart of it was, I think Ed really felt that GCSH was more of a pass-through agency, and that the provider organizations should be the ones determining who should receive the funds. And then Isabel clarified to Ed that really it's the ACH, it's the board of directors that have authority over the funds. But this keeps coming back up for whatever reason, that some of the providers feel that these are their funds and that we shouldn't be interfering in their funding.
That was the biggest complaint. One was brought up in the meeting on Tuesday, and I didn't have this email in the meeting on Tuesday. We will be going back to the providers again in 2 weeks, and I will bring this letter, but they kept saying they want clarification from HCA. Well, we've already got the clarification.
So, and we have that in the board minute. So
Yeah.
I guess my feeling is that we've had that discussion,
Mm-hmm.
and that really our charge is to look at what you've recommended and have the board have a discussion about the formula, the milestones, the deliverables, and what's accountable. So is there anyone that disagrees with me on that discussion from the board?
No, I agree.
Okay, so let's go forward with our discussion. So why don't you finish the presentation and let's talk about what you're presenting.
So what we presented to the Budget and Funds Flow Committee last Tuesday, I think it was a payment structure, and I'm referring to this sheet. So on the first side, it highlights the amount of funding that has already gone to the behavioral health organizations. So you can see the list of providers is on the left side. With there were two allocations. One was the original allocation amount, and then there was funding left over at the end of the year that was put into a contingency pot of money, and then we allocated the contingency funds based on the same funding formula. So on the right-hand column, you'll see that each one of these organizations received anywhere from $88,000 to $1.1 million. On the flip side, then, is what we presented as a funding formula to the Budget and Funds Flow Committee, and we used the same components for practice transformation, those milestones that Jenna and Martine referred to in that toolkit, and we lined them up so you can see that the funding is very similar, except for some areas like the base population health infrastructure is a little bit less, based on Sam's analysis of what the behavioral health organizations would need. The assessments that they have already received funding for, which is a policy of the board not to double pay any organization for the same work. We eliminated the care management milestone in under 2B3, and these are in red, so you can see them highlighted. However, medication management is totally relevant to the work that they do. The health information technology, again, something that was covered under the previous allocation. And then Sam will have to remind me again of implementation of pre-managed and EDI, but I think it has to do with the fact that they don't have EIHRs.
Well, they're going to be sponsored.
Right, they're sponsored by the MCOs.
Okay. So each organization then would be eligible to receive $247,743, which is very similar to the allocations that the providers are receiving under practice transformation, if you add up previous funding that they've gotten from the mid-adopter first allocation.
I think, sorry, Carol, got lost. So is that amount per organization?
Yes.
Yes.
So same amount for every organization?
Yes.
Regardless of the size?
Right. Which is what we've done with practice transformation.
With primary care, you mean?
Yes, with primary
And what you did with the hospitals?
Yes.
Regardless of size of the hospital?
Yes.
Yes.
So this is Darlene. There was obviously a lot of conversation with the Budget and Funds Flow Committee, and for some members of that committee, a lot of this information was new because they'd come on kind of in process with this, and obviously it's differing from the previous model. But I think we have to really look at the fact that our goals are different from the previous model. And so at the end of the meeting, the Budget and Funds Flow, the major portion of the Budget and Funds Flow Committee moved to pass this on to Finance and the board for acceptance.
Okay. Were there any discussions during that Budget and Funds Flow, Darlene, that you think would be helpful for the board to know?
You know, a lot of it was really clarification. It was looking at how this was formulated, how it compares to what the practice transformation, what's being done with the hospitals as well as primary care. There was a few questions around how are we ensuring that primary care, EDs, and behavioral health are really working together and that people aren't falling through the gaps? And will this kind of funding that has kind of three different silos really meet those needs and continue to reinforce those three systems to work together? That was certainly one thing that I think was kind of a highlight that came out of that. We probably had about a 45-minute discussion about this. Carol, do you recall other things that you felt like were pertinent?
I do. I think some of the questions, though, Darlene, came from members that were really new to the whole process.
Yes, they did.
Needed of, how did we come up with this funding formula since it's so different than what we were proposing? And we're not that familiar with even the patient-centered medical home funding. So I think David Giuseppe is probably still a little bit confused. Scott Olander was not. I don't think he was aware.
Isn't he? Where's he now?
He was at Kittitas. Yeah. So he had some questions about Kittitas's funding, and we sent him information about what they were receiving for practice transformation.
Yeah. So Darlene, Carol, and I had some after meeting conversations just through emails with Scott and David about their questions and concerns during the meeting. I think we clarified. I haven't heard from them since that. Right.
Dana.
Yeah, I have a question on the deliverables. Will there be ways for some of the smaller behavioral health agencies who, let's say, are but who are focusing on substance use, let's say, who maybe right now don't have as easy access to like the bidirectional integration or the medication management pieces to be able to earn the incentives?
So, yes, and actually we've seen that happening already. So like a standalone SUD that we're working with right now is Somerset, for example, and they're partnering with Catholic Charities to do like a mental health collaboration. Their ultimate goal, what they were thinking about was bringing in Cadillac for like a primary care piece to do that kind of 3 trifecta. They're still working on integrating the primary care side, but they're like fully integrated with SUD and mental health. Also like a smaller one that's not even SUD, but WISE, which is like Lutheran Community Services. They've hired a full-time ARNP. So there's places that are smaller that can still do the deliverables.
Well, and I think that the fact that there's consistent funding, even to the small organizations as well as to the large organizations, addresses that equity, so that these areas, you know, when you're looking at the total funding, really benefits organizations that are also small to really enhance and put these factors into place.
Uh-oh.
Are you still there?
Is that her, or is there anybody else on the phone? Can anybody hear us?
I'm still on the phone. This is Darlene.
Okay.
We're waiting quickly, Darlene.
Dropped off for just a minute.
So let me just ask, were you at the meeting?
I was not.
Okay.
No, I was not.
So from behavioral health system provider, does this make sense to you?
Well, I think if we're trying to align with what we're doing for, you know, our practice transformation, that is in line with what CACH is doing. It's certainly different than what the behavioral health organizations are used to. So I understand that, but you know, like the question I was asking was just making sure that the agencies that maybe don't have as much access as some of the larger agencies, that they're also able to, you know, have the ability to earn these as well.
And that's also something that we promote. Sorry, I don't have the right thing in front of me. But care coordination, like that's one of the milestones that you're, Dana, familiar with like the practice transformation side. But that is one of them. The questions that would more than likely be asked of the behavioral health organizations is who do you collaborate with and what community partnerships are you promoting? So we try to touch on that in like different areas as well. But some of the feedback we've gotten, Martina and I, since we've met since Tuesday with some of the behavioral health agencies, was that they would like more like description on what does empanelment mean necessarily for a behavioral health agency. Unfortunately, in the meeting on Tuesday, we didn't get to define that, but that just was some of the feedback we've gotten.
Well, so do you guys can provide support for that?
Yeah, that was going to be my comment. Similar to practice transformation with primary care, Jenna and I are going to be the practice transformation navigators for the behavioral health organizations and do the same process, you know, help them through each milestone, kind of do the hand holding, provide resources, connect them with other organizations to have that, you know, integration if they need that integration within their agency.
Don't you guys already meet with them on a regular basis?
Yeah.
You do.
So
it'll be more than that.
Yeah, it'll be way more like in depth, but we already still have good relationships that we've maintained from like the INC transition and stuff.
Okay, before I go to Diane, let me just see if Darlene is back on the phone.
Yep, I've been on the phone the whole time.
Okay, it sounded like we cut you or somehow we got disconnected. So would you finish your thought, please?
I think actually I've said everything. I feel like the final conversation of the Budget and Funds Flow Committee was really around the fact that giving an equal amount of funding and having these deliverables that conform with both the practice transformation and work with primary care and EDs is a consistent process, and that this supports both the large as well as the small organizations to move ahead in the same direction at the same time frame.
Okay, thank you, Darlene. Sorry.
So I also need to say that I will abstain from this vote because we are a behavioral health organization as well, but I just wanted to report back from the committee perspective about what was discussed.
All right, thank you for that. Carol and then Diane.
I think one of the final pieces too is that we had hoped to go through the milestones on Tuesday so that we could explain to the behavioral health providers what they meant and to have a dialogue to make sure that these milestones meet up with their needs. We didn't have the opportunity to have that conversation. But we are having a provider meeting in 2 weeks, at which time we would like to have that conversation, because there might be something that we are missing. But as long as we have a structure of a fund, that we can work with them on, I guess the permission would be is if we could be permitted to use the base level of funding, but if there's something that needs to be tweaked within this formula that we, similar to what we did with the hospitals in terms of, the empanelment risk stratification might not make sense for a hospital, and so we combine those categories, and we can always bring that back to the board. But I think initially we would just like to have the authorization to use these funds according to the budget that was laid out.
Diane?
That was pretty much what I was going to say, is that we're hoping that, if there that needs a little bit more funding to do the infrastructure, that would be able to stay within the 247, but be able to have the flexibility to change it if they need it, to apply it in a different way. And then also it's going to give the providers more support and technical assistance, because the practice transformation navigators, as well as myself and Sam too, are all available for them to have the support from all of us. So hopefully at the next meeting, which is in 2 weeks, it's a 2-hour meeting, and hopefully we'll be able to get through the milestones and explain it to them better, so that they can understand that it is feasible and it's something that can be worked through for the behavioral health agency.
I guess my question is with bringing this group on, is 2 navigators enough to support all the primary care and hospitals and behavioral health?
They're kind of already doing it anyway.
Yeah. Okay.
Right.
That's their problem. Okay.
We do have one. We do have a budget for one other one. If
it just seems like a lot. I mean,
we've
you guys are all over.
Without Sam.
It's 3 navigators with Sam.
Yeah.
Okay.
Some of the kind of benefit, because it does, like on a paper, it looks like a lot, but what we've noticed with a lot of the sites is that, and what we planned was that somebody internally would take ownership of it and keep it going. So at a lot of the sites, we have people who are like internal practice transformation champions.
Yeah.
So they've like organized people within their organization to get like a provider champion and their data analyst, and they keep that going and keep those conversations going. They pull us in. We're there all the time. Like, we feel like extra staff, but they are really championing that, so that if we're not a center of excellence in 2022 or something like that, they would still be able to keep that going.
Okay. Yeah. Okay. Do people feel like they have enough information to make an informed decision?
I'm still trying to understand the impact that this could have and could be different depending on the size of the provider. And the reason why I'm trying to understand that is I want to understand how much of an incentive this would be to really take on this transformation for a large provider versus a very small provider, if this becomes 1/3 of my budget versus 1/20th of my budget. So what we are saying is that all providers, big or small, would receive the maximum same amount of dollars. Is that what we're saying?
Yeah. Yeah.
So how do you see that in the context of reality of Greater Columbia, is that we have very large providers for which these stipend or this allocation would be small monies, that they have a big impact in the community because they see a lot of people, versus the smaller ones. And I've always protected the smaller ones, but I'm trying to look at as a CEO that says, okay, 2% of my revenue for how much work, excuse me?
They're already doing it. The larger organizations are already doing this at one site or another. Like Comprehensive is already doing it at 2 sites, and Lord is doing it.
So you don't see a problem on embracement of the project?
It may be, but there also, if you look at the amount that they were funded the first round versus the smaller organizations were funded so little versus the larger organizations. So I think it kind of.
Yeah, no, I understand that, but if I am the CEO of a larger organization, that is not my problem, that's a smaller organization's problem.
And
Well,
Jorge,
that's
I
not
do
a
not,
solution.
I don't disagree.
Yes.
So who is that on the phone?
That's Sam.
Okay.
This
Go ahead.
is Sam. So this is not per organization, this is per clinic setting. So what we do is an assessment based upon, and this is analysis of an estimated of what it costs per clinic setting based on their panel patients. And it's based upon their patient population as a whole, not just the Medicaid demonstration, but their entire population. And what that would look like per clinic, whether it's a small clinic or a larger clinic, it primarily is looking at the same. So you're looking at your set patient population that's per provider, per team member, and it's process oriented. So you're implementing processes across the board. So these estimates are based on the time that is input for that QI team to get together, or whether it's a process to be able to take that time out for risk stratification of what that might look for that body to be able to do that, and for this company or this clinic to be able to participate in making sure that these quality improvement measures are happening. But then also the sustainability piece that Jenna was talking about, it's really train the trainer and then make this part of your everyday operation. So it's not per se that we're taking all of these different milestones and throwing them at them. We're doing a process improvement, quality improvement per clinic setting, and it's based across the board for the population.
So what I was going to say, thank you, Sam, for that, is that you've got Providence and you've got Garfield.
Mm-hmm.
They're receiving the same amount of funding, right? Providence obviously a lot bigger.
Mm-hmm.
How do you move a big ship like that? Well, you know, that's why we're working with all of the hospitals to figure out, does this make sense for them? But when we went through the original scoring process, the practice transformation work group, and then it came to the board, we asked about the 8 change concepts, and volume is as one of those change concepts, and it scored one of the least amount in terms of when you're looking at the concepts that it takes to make organizational change. Leadership was the most important piece.
Mm-hmm.
So we've already been through this exercise to take a look at what is the most important in making a change organizationally, and it's really leadership, and that's how we selected our first set of provider organizations. Now, we will give an option to the behavioral health providers if they don't want to participate in this. They don't necessarily have to, but we haven't had the opportunity to have that conversation.
I think that's the end of my comments, because I don't know all these details. I think detail enough to even have a strong opinion on this, but I do know that it's very critical, and everything we do in integrating behavioral health is very critical that the providers are really engaged, because they're the new kids on the block. You know, I've been working with hospitals and with primary care clinics for decades. The providers, the behavioral health providers are the ones that we want to make become part of this new system. They have different realities, they have different customs on funding streams, etc. So as much as in prior meetings I've been speaking for the smaller providers, I want to make sure that the degree of engagement of the larger providers remains consistent, because we need them all of any kind.
Okay.
And just a clarifying question.
Yep.
I thought I heard Sam say that it was based off of sites. That this?
It's we're one site per organization.
Okay, one site per organization. Okay, got it.
Yeah.
Brenda, this is Darlene. I'm sorry I need to sign off just because I have another meeting.
Okay, we're going to vote. Do you want to stay on? Oh, you're going to abstain. Okay, got it.
I'm
Thank
going
you,
to
Darlene.
abstain. All right, thank
Got
you. Bye-bye.
Thanks, Darlene.
Okay, would someone like to make a motion
I have a question.
regarding the staff recommendation? Is it really important, Ronnie?
Yeah, do
Okay.
I have to abstain because I'm with Lords, but I'm representing the consumer?
You probably do need to abstain. Because Lords would be recipient of this, right?
So do we have quorum?
Yes, yeah, you'll have quorum. I would go ahead and make a motion to advance this funding in the manner that is presented by the staff.
Is there a second?
I'll second it.
Second by Eric. Any further discussion? All in favor?
Aye.
Aye.
Is anyone opposed? How many abstentions do we have? 1, 2,
Darlene.
and Darlene.
3.
Okay, the motion is passed. Great discussion. Thank you, everyone. We've already really recapped the April board retreat. It's 3 o'clock. Do we need to talk more about that, Carol?
Just that, at your leisure, your reading, if you want to have something to fall asleep to at night, you can read the crosswalk of all of the different discussion items. And what staff tried to do is to show you that a lot of what you envision, your vision of the future is already happening through some of these milestones and some of the initiatives that Greater Columbia has already taken.
That's sort of in recognition that there are some new people to the board. I mean, I understand all of the context of the work that we've done. So that crosswalk helps address that to let you understand what we're doing.
Great. Okay, would someone like to make a motion to adjourn?
So
I
moved.
motion, please.
I'll second.
I've got a motion and about 15 seconds. Meeting is adjourned. Thank you, everybody. And are we meeting in June?
No.
Okay, so we won't meet in June.
You have to be in Jamaica or somewhere with these people.
Oh, boy.
It's gonna be hotter here than Jamaica.
Because it's the week of Summit.
Thank you. Bye-bye.
Ronnie.
I thought Ronnie,
Thank you, everyone.
I adjourn. I said I made
Okay.
second.
motion.
And then.
Jorge
There was a lot of them.
Or
So
You see, yeah, that was the most.
Everyone was.
It was Ed and I.
Thank you, Ms. Rhonda.
Clarification from HCA.